The next abstract is Optimizing Diagnostic Technologies for Pediatric HIV, Function or Location, Modeling Analysis of Point-of-Care Technologies in Matabeleland, South Zimbabwe, from Clare Flanagan.
Good morning. I'm very honored to be here today on behalf of our research team. While the modeling work for this analysis was done in the US, most of the research and policy questions were really driven by our colleagues at the Ministry of Health and Child Care and the Organization for Public Health Interventions and Development in Zimbabwe. Other team members have presented on this work, shown here. And for more information, please be sure to see our poster at the main conference. We sought to evaluate the use of a location optimization model to inform point-of-care device allocation in such a way that maximized the number of children with HIV starting antiretroviral therapy within 30 days of testing. As background, conventional laboratory testing for infant HIV diagnosis may take several months to return results, and many caregivers never receive results due to drop-off throughout the testing cascade. Meanwhile, point-of-care technology can improve access to infant HIV testing, can reduce time to result return, and it can increase the proportion of children with HIV who are diagnosed and initiate ART. And all of this together may result in improved survival among children with HIV. However, the supply of point-of-care devices is limited, in large part because they are costly. And device functionality can vary, which can impede the clinical benefit of these machines. Finally, it can be challenging for programs to decide where to best locate these devices. Our objective was to determine how to achieve 50% 30-day infant ART initiation. Could this be achieved by optimally locating devices? Or would it also require improving device functionality? Or perhaps also adding additional machines? This analysis focuses specifically on the Matabeleland South Province in Zimbabwe, which has an overall HIV prevalence of 18% and currently has access to 11 point-of-care devices. Moving into our methods, we developed a location optimization model. This is an integer programming model that uses mathematical methods to rigorously determine the most efficient allocation of limited resources, in this case, point-of-care devices, while maximizing the outcome of interest, in this case, 30-day infant ART initiation, while also accounting for constraints. Here, the number and functionality of point-of-care devices. We seed the model inputting routine data from the Matabeleland South Province, and then the model gives us our final outputs, including the optimal assignment of point-of-care devices, the percent of results returned to caregivers within 30 days, and the percent of infants who initiate ART within 30 days of a positive test. We modeled the cohort of infants who underwent HIV testing from January 2019 to January 2020 using routine data from 122 health facilities across 7 districts in the Matabeleland South Province. This cohort then informed our specific input parameters. For the number of infants presenting for testing, this was health facility specific and varied by month, ranging from 0 to 65. Test positivity was district specific, ranging from 1 to 4%. For 30-day result return to caregiver, for those infants undergoing conventional laboratory testing, this was district specific, ranging from 15 to 43%. And for infants undergoing point-of-care testing, we used 98% for 30-day result return. Finally, we used 95% for ART initiation among children with HIV who received their test results. For device functionality, we defined this as the proportion of weekdays when a point-of-care machine was working. Functionality depends on resources, including those resources required to establish point-of-care platforms, such as initial training and investment in power sources, as well as resources required to maintain point-of-care platforms, such as routine machine maintenance and test cartridges and reagents. Functionality in the 2019 data varied by district, ranging from 35% to 98%, with a mean of 63%. Moving into our results, or how to achieve that 50% 30-day infant ART initiation target, and I'll just stress, this 50% target specifically refers to timely 30-day ART initiation and not overall ART initiation. The maps here show the number of point-of-care devices assigned to each of the 7 districts within the province. Under the current allocation shown in purple, we would expect to see 37% of results returned to caregivers within 30 days, and 35% of infants initiating ART within 30 days. Under the optimal allocation shown in blue, these numbers would increase to 46% result return and 44% ART initiation within 30 days. Importantly, this optimal allocation would suggest moving 8 of the 11 current devices from their current placement. But what you'll also notice is that this optimization would leave 3 districts within the province without access to any point-of-care devices. Of course, this is concerning from an equity standpoint. When we reran this first part of the analysis, with a constraint that required each district within the province to receive at least 1 point-of-care device, we found that 30-day ART initiation dipped only slightly to 42%. These equity considerations are very important and will be the focus of future analyses. For now, though, I will refocus on the original analysis with the intent of evaluating this mathematical methodology. So you can see, comparing the current allocation to the optimal allocation, that the optimal allocation moved closer to that 50% target, but didn't quite get there. So what if device functionality also improved? As a reminder, functionality was defined as the percent of weekdays when a device is functioning. Current functionality was district-specific, with ranges shown, with a mean of 63%. But we also evaluated a high functionality scenario, in which we varied those district-specific values by plus 30%, giving a mean of 75%. Results for the current functionality are shown in the graph in purple, with high functionality shown in blue. And you can see when devices are optimally located and when they're functioning at high functionality, or a mean of 48%, or a mean of 75%, we achieved 48% 30-day infant ART initiation. So moving closer to that 50% target, but again, not quite there. So what if the province could also acquire new devices? We found that if devices were operating at high functionality, the province would need 15 total devices to achieve that 50% 30-day ART initiation target. That's an increase of 4 devices over the currently available 11 devices. If the devices were operating at current functionality, the province would need 25 total devices to achieve that 50% target. And importantly, if device functionality dipped to a mean of 44%, the province would need over 100 devices to achieve that target. In conclusion, optimizing point-of-care machine location would substantially increase 30-day ART initiation among infants with HIV. Programs can maximize the clinical impact of point-of-care infant HIV testing by planning for the resources required to establish and maintain point-of-care device functionality. For next steps, we will incorporate questions related to costs, asking what resources are required to move existing point-of-care machines or to acquire new machines. And what are the long-term infant HIV care costs incurred or saved with improved access to point-of-care testing? We'll also incorporate questions related to equity, asking how can equity in point-of-care access be ensured across locations and populations? And what are the clinical and economic impacts of doing so? We hope that we've demonstrated that modeling analyses can act as valuable aids for decision makers. We'd like to thank our funders, thank the conference organizers, our collaborators, and thank all of you for your attention.